Good day, dear doctors. Today we are going to discuss a scenario that we often come across in our pediatric practice. It's a common situation, but as we all know, dealing with pediatric cases can sometimes get quite complex due to their unique physiological responses, communication limitations, and the broad spectrum of possible illnesses. Our case today revolves around a little patient, just 3 years old, who came to our attention under quite distressing circumstances. They were accompanied by their understandably concerned parents, who reported that the child had been experiencing a high-grade fever for the past 2 days. This wasn't just a minor temperature rise, it was a noticeable, persistent fever, the kind that naturally alarms parents and clinicians alike. But the fever wasn't the only concern. The child, usually active and responsive, had become increasingly irritable. They were not their usual self, showcasing discomfort and agitation. Moreover, the child showed a marked change in appetite. They were refusing to eat, a symptom that always warrants thorough investigation in children. Each of these symptoms in isolation could be a potential red flag, an indicator of an underlying issue. Together, they form a clinical picture that has caused significant worry for both the parents and us as healthcare professionals. So, let's dive into this case, study it in detail, and see what we can learn from it. Our ultimate goal is to better understand such situations, to enhance our clinical knowledge, and to continually improve the care we provide to our young patients. Please bear in mind, the lessons we glean from this case won't just enhance our individual practices, but collectively, they contribute to the overall quality of pediatric healthcare. And in doing so, we move a step closer to ensuring the well-being of our young ones, the future of our society. Let's get started. Now, let's dig a bit deeper into the history of our young patient. As I've already highlighted, our primary concerns were the high-grade fever that has been ongoing for 2 days, a noticeable change in the child's behavior marked by increased irritability, and a concerning refusal to eat. Let's first consider the fever. Fever in children isn't uncommon, as you well know. Kids can develop a fever due to a wide range of reasons, from mild viral infections to serious bacterial diseases. However, the persistence of a high-grade fever over a couple of days is a red flag. It suggests that the child's body is fighting off something more substantial, potentially more sinister. Then we have the noticeable irritability. Kids, especially toddlers, are known for their mood swings, but when a usually happy and lively child becomes consistently irritable, it's a clear signal that they are not feeling well. It's their way of communicating that something is wrong. Something is bothering them. Additionally, the child's refusal to eat was a significant symptom. Any change in appetite, particularly a complete refusal of food, is always a concern in children. It could signify a variety of health issues, including gastrointestinal problems, or it could be a response to general malaise or discomfort. Taken together, these symptoms presented a worrisome clinical picture that required urgent attention. Importantly, the parents reported that both the loss of appetite and the behavioral change were out of the ordinary for their child, which made the situation even more pressing. As for other aspects of the child's history, there was no significant past medical history that could provide us with clues about the current situation. The child hadn't been traveling recently, which ruled out a range of travel-associated illnesses. Also, the child's vaccinations were all up to date, which is always reassuring news as it lessens the probability of several serious childhood diseases. So here we were, with a high-grade fever, a noticeable change in behavior and eating habits, but no immediate hints from the child's medical history. It's these situations that remind us how each case is a unique puzzle waiting to be solved. Our next step, therefore, was to conduct a thorough physical examination and move forward with appropriate investigations. During the physical examination, the most evident finding was the child's high fever, which was consistent with the parents' initial report. A high fever in children can often make them lethargic or irritable. Both these symptoms could be clearly seen in the child's behavior during the examination. The child was noticeably fussy and less responsive than what you would normally expect from a 3-year-old. Normally, kids at this age are curious and interactive, but this little one was clearly not in the mood for engagement, an observation that again pointed towards some form of substantial discomfort or illness. Despite these clear signs of distress, there were no immediate signs of respiratory distress such as rapid breathing, use of accessory muscles, or nasal flaring, which could have pointed towards a respiratory infection. This is always one of the first things we check when a child presents with a high fever, as respiratory infections are quite common in this age group. In addition, the child did not present with any rash on the skin. Skin rashes can often accompany fevers and several viral or bacterial illnesses in children. So the absence of a rash was significant in narrowing down our differential diagnosis. The lack of other definitive symptoms made the case more complex. It's in such situations that we are reminded of the challenges of pediatric practice. Children often cannot articulate their symptoms or where it hurts, and we need to rely on our observational skills and experience to interpret the signs they present. So, after our initial examination, we found ourselves with more questions than answers. We knew the child was unwell. The high fever, the irritability, and refusal to eat were clear indicators. But we needed more information to reach a diagnosis. This led us to the next step in our process, further investigations. When the physical examination does not provide a clear diagnosis, further investigations become necessary. In the case of our young patient, their persistent high-grade fever, irritability, and refusal to eat could indicate a number of conditions, many of which could be infections. So, the logical next step was to conduct tests that could help identify if an infection was the underlying cause. 3 main tests were ordered: a complete blood count, urine analysis, and a throat swab. The complete blood count, often simply referred to as a CBC, is a commonly used test that evaluates the cells that circulate in the blood. In this case, we were particularly interested in the white blood cells, as an increase in their number can be a sign of an infection. We also looked at other components like hemoglobin and platelets to rule out other conditions such as anemia or dengue, which are also common in this age group. A urine analysis was also conducted. This test involves examining the urine for various substances, including white and red blood cells, to check for any abnormalities. A urinary tract infection could also cause a high-grade fever, especially in a child that's refusing to eat and is irritable. Hence, this was an important investigation to carry out. Finally, we also took a throat swab. Throat infections, including strep throat, are quite common in children and could explain the symptoms we were seeing. The throat swab would allow us to either identify or rule out this possibility. Each of these tests aimed to uncover any hidden infection that could be causing the child's distress. Our objective was to gather as much data as possible to guide our diagnosis and management plan. When the symptoms are common ones like fever and irritability, a wide range of diagnoses need to be considered. Our goal was to narrow down this list based on the child's specific symptoms and test results. At this stage, we're leaning towards several possibilities, which include common childhood illnesses as well as less common, but serious conditions. One of the possibilities was otitis media, which is an infection in the middle ear. This condition is very common in children and could potentially explain the high-grade fever and irritability. However, the child didn't have any ear pain or discharge, common symptoms of otitis media, but these can sometimes be absent or hard to ascertain in a child of this age. Another condition we considered was strep throat, a bacterial infection that could cause a high fever and also possibly explain the refusal to eat due to throat discomfort. The throat swab test we took would help us determine whether this was the cause. A urinary tract infection was another possibility. Even though they're less common in children than adults, they can still occur and might lead to similar symptoms as we were seeing in our young patient. That's why we included the urine analysis in our list of tests. Lastly, we also had to consider more severe conditions like meningitis. Though less common, it's a serious condition that could explain the symptoms, and its possibility dictates that we must maintain a high index of suspicion for it in children presenting with high-grade fever and irritability. While we were pondering these possibilities and waiting for the test results, we began managing the child's symptoms. The child was clearly uncomfortable due to the high fever, and we initiated treatment with acetaminophen. This common medication helps lower fever and should reduce the child's discomfort. In essence, our approach was a combination of analyzing the patient's symptoms, comparing them against various potential diagnoses, ordering appropriate tests, and initiating symptomatic treatment. The goal was to find the right diagnosis while ensuring the child was as comfortable as possible during the process. The management of any illness becomes clearer once you have a diagnosis. In our case, it was the results of the tests we had ordered that provided the key. The complete blood count came back normal, indicating there was no overall increase in white blood cells, which is often seen in systemic infections. The urine analysis was also clear, ruling out a urinary tract infection. However, the throat swab test revealed the presence of streptococcal bacteria. This was the clue we needed. Strep throat, an infection caused by streptococcal bacteria, was the source of our young patient's discomfort. These bacteria often cause a severe sore throat, high fever, and sometimes they can cause a child to refuse food because swallowing becomes painful. In a 3-year-old, who might not be able to articulate what they're feeling, these symptoms could be shown as irritability and refusal to eat. Armed with this diagnosis, we started the child on an appropriate course of antibiotics, which are highly effective against streptococcal infections. Besides that, we continued with the symptomatic management of the fever and ensured that the child was kept hydrated and comfortable. As healthcare providers, there's nothing more rewarding than seeing a patient improve, and in the next few days, that's exactly what we saw. The high-grade fever that was the cause of so much discomfort began to resolve, and with it, the irritability reduced. As the child began to feel better, the appetite returned, and they started eating again, much to the parents' relief. It was clear that the child was on the road to recovery, confirming that we had made the correct diagnosis and the treatment was working. Reflecting on this case, we're reminded of the unique challenges that come with pediatric cases. Children, especially those as young as our 3-year-old patient, often cannot express or articulate their symptoms clearly. They can only communicate their discomfort in ways they know how, in this case, through irritability, refusing to eat, and the clear sign of a high-grade fever. It is upon us, as healthcare providers, to interpret these signs correctly and carry out appropriate investigations to reach a diagnosis. Diagnosing in pediatric cases is a bit like solving a mystery with only a handful of clues. Symptoms can be vague or non-specific, making it difficult to pinpoint the exact cause. The symptom of a high-grade fever, for instance, is a non-specific response to a variety of infections and doesn't point us directly towards strep throat. However, the potential risk of complications from untreated strep throat added an element of urgency to our case. If left untreated, strep throat can lead to more serious conditions such as rheumatic fever and kidney inflammation, posing a serious risk to the child's health. This case underscores the importance of a thorough investigation. By ordering a complete blood count, urine analysis, and a throat swab, we were able to rule out other potential causes and narrow down our diagnosis to strep throat. It was a careful and cautious interpretation of the child's symptoms, along with the test results, that led us to the correct diagnosis. Looking back, this case is a powerful reminder of the importance of being thorough and meticulous in our investigations, especially in cases where our patients are unable to communicate their symptoms effectively. Each case is a learning experience, and this one certainly emphasized the value of thoroughness and caution in pediatric practice. As healthcare providers, we aim to align our actions with the latest and most reliable research available. We refer to this as practicing evidence-based medicine. In this case, our strategy to manage our young patient's symptoms and our approach to her diagnosis and treatment were in line with established guidelines and best practices for managing fever in children. Fever in children can be a symptom of a myriad of illnesses, ranging from mild viral infections to more serious conditions. Our first step, as per recommended guidelines, was to perform a thorough examination. This included both a physical examination, to look for any obvious signs of illness, and a detailed patient history, to understand the progression of symptoms. In our patient's case, the fever was high-grade and persistent. the child was increasingly irritable, and she refused to eat, all symptoms that justified further investigations. Following guidelines, we ordered a complete blood count, urine analysis, and a throat swab. These tests helped us to identify or rule out potential causes of the child's symptoms. When the throat swab revealed the presence of streptococcal bacteria, it confirmed our diagnosis of strep throat. Evidence-based guidelines advocate the use of antibiotics to treat strep throat and prevent complications. Accordingly, our young patient was started on an appropriate course of antibiotics, which led to a significant improvement in her condition. In conclusion, our approach to this case was driven by established clinical guidelines and the principles of evidence-based medicine. This not only guided our decision-making process, but also provided our patient with the most effective and appropriate care for her condition. Reflecting on today's discussion, this case brought forth several key takeaways. The most significant is the understanding that common symptoms, like fever in children, can sometimes pose a diagnostic challenge, especially given the range of potential underlying causes. It can be anything from a minor illness to a symptom of something much more severe. It is critical that we as healthcare providers approach such cases systematically. The case of our young patient, who had a high-grade fever, was increasingly irritable, and refusing to eat, underscores this. These symptoms are not exclusive to any one illness, but are common to many. This situation urges us to perform a thorough and systematic examination, and order appropriate investigations. In our case, this approach led to the identification of strep throat as the underlying cause. Another important learning from this case is the understanding of how severe common illnesses can become in children if left untreated. In our case, strep throat, a commonly encountered childhood illness, could have led to serious complications if not identified and treated in time. It is our responsibility to keep such possibilities in mind and always consider a wide range of potential diagnoses when faced with non-specific symptoms. Moving forward, our action plan involves integrating these learnings into our daily practice. We need to remain vigilant, carry out comprehensive assessments, and ensure we are always prepared to handle diagnostic challenges like these. It's not just about treating symptoms, but about identifying the root cause to provide the most effective care for our patients. This brings us to the end of our case discussion today. I'd like to extend my thanks to all of you for your attention, your engagement, and your commitment to continual learning and improvement. Together, we can make a positive impact on the health and well-being of our patients.